Sanjaya, thank you so much. I really appreciate all your incredible work, education work, and good morning, good afternoon, good evening to people throughout the world. We're going to be talking in depth about the world of hepatitis B. And yes, there's a lot of things happening leading us towards a functional cure. And I'm going to give you a peek at some of the new medications that are in develop a little bit later during this presentation. To get to a functional cure, it's very important to be thinking about testing, linkage to care, much earlier treatment of individuals. And there's a lot of, I'd say, niche areas in the hepatitis B world that we need to be thinking about as well. Although our real goal at this time is to make things as simple as possible. The complexities of the guidelines historically, in my opinion, have been a big problem. Let's dig in. Disclosures are at my website, robertgish.com. I also have a newsletter where you can sign up and communicate with me through the newsletter or through the website. And there's many resources on this website as well. And really focusing on liver disease and liver health. I'm also happy to communicate with you all by email or other methods to stay up on what you think are priorities. So what are we going to talk about today? We're going to really give you a big picture, 10,000 foot, 5,000, 1,000 foot to think about hepatitis B, and then get down to a little bit of the micro level. We talked a little bit more about how the natural history of hepatitis B, how this impacts patients, some facts and fictions. There is a whole issue about hepatitis B that is stigma related because of misconceptions about what's happening in the hepatitis B world. I'll talk a little bit more about the core antibody test. It's taken me 20 years of advocacy to get some of the fake news about core antibody tests out of the literature and really think about how core antibody can be used in your clinical practice. We'll touch very briefly on things such as pregnancy and liver transplant. And we'll have a pretty expanded discussion about new treatments. The exciting thing is there's at least 30 new medications and about 20 companies in the hepatitis B space. Few companies have come and gone, but for every company that was in hepatitis B that exited, such as Janssen, 3 or 4 new companies have entered this space with some very exciting technology. When you think about hepatitis B, there's 2 ways to go down this pathway, and that is how many people are surface antigen positive. And the current number, according to the Polaris Institute, is 257 million people. The number in the US is up to 2.4 million. That's the paper that Robert Wong and I published a few years ago. But 70+% of hepatitis B is in the Asia Pacific and Africa region. So we really need to be thinking globally about when we talk about hepatitis B, when we're writing guidelines. And there's 1 million people dying every year from hepatitis B. And the death rate has not changed in the last 20 years, in spite of all the different guidelines that have been written about hepatitis B. We haven't moved the dial. We haven't changed the death rate. And I'll get into that in multiple different directions today. Well, we've had the advent of vaccination, an incredible decrease in the number of hepatitis B cases from an incident perspective. But there's still countries that don't have birth dose vaccination as part of their policy. Right next door, Canada doesn't have a nationwide birth dose hepatitis B policy. And there's multiple countries in Europe that don't offer hepatitis B birth dose. Fortunately, in the US, the birth dose vaccine has made a major impact as it's broad-based, it's simple. Although there's over 1,000 cases a year of hepatitis B transmission from mother to child in this country, but 1,000 is quite low relative to the historical perspective. It would be very nice if we got close to 0. All right, when we think about hepatitis B, this is a typical beginning slide. We want to prevent cirrhosis. We want to prevent liver cancer. We want to prevent transplant and death. But what's missing from this slide is what's a major issue to patients. And I mentioned stigma earlier. There's also quality of life issues that are very important. Infectivity, of course, mother to child transmission is important, but there's horizontal transmission of hepatitis B globally in a variety of different settings. Hepatitis B has effect on different organ systems. It's an inflammatory state. And some patients have really severe somatic symptoms. It's also linked to other cancers similar to hepatitis C. So we have many reasons to treat individuals, and I will get to that point shortly. But these factors have been left out of the guidelines for years. There's a patient voice letter that we just wrote that was published in Lancet Gastroenterology. I highly recommend that you read that about how a patient should have a major involvement in choosing whether to be treated or not. The guidelines historically have been extremely structured, all about ALT, DNA level, e antigen status, histology, but no one listened to the patient. So let's think about this as being patient-centric now. This gives you some issue about gaps in terms of testing and linkage to care. You have prevalent, diagnosed, and treated here for HIV, hepatitis C, and hepatitis B. Under 5% of individuals with hepatitis B are being or have been treated. One of the main reasons for this gaps is our guidelines, in my opinion, are out of date, complex, and a barrier to access. HIV, we treat everybody. Hepatitis C, we treat everybody. Hepatitis B, we have 36-page guidelines. Let's make this simple. Take a look at what I've written called the 5-line guideline. That's been published in various forms in 3 different publications, peer-reviewed publications, and we'll get into that a little bit later. As you recall, this is a DNA virus, very compact, very efficient. It makes a variety of different proteins and molecular structures. It has a DNA polymerase, which we used to measure 30 to 40 years ago as a marker of replication. That was replaced by DNA. E antigen is still an important test. This is a test that really describes what phase the virus is in from a molecular perspective. And of course, our surface antigen is made up of 3 different types, but our surface antigen assays measure all of these specifically. Core antigen is measured indirectly through what's called correlated antigen, but Abbott actually has a direct core assay that has a phosphorylated and unphosphorylated version that may reach the clinic, but it is super important in terms of drug development. We also measure pregenomic RNA. There's multiple different assays for this. Again, an important part of drug development. The other key issue about hepatitis B is that once you have this, you have hepatitis B for life. Core antibody positivity equals the presence of cccDNA, and I'll describe that in a little bit more detail later. But this integration is super important in terms of carcinogenicity, oncogenicity. And we'll talk about the integration world from a couple of perspectives a little bit later also. We have A through J genotypes, and we also can measure core and pre-core mutations. We can measure cccDNA, but cccDNA measurement requires a liver biopsy or a fine needle aspirate. Let's make this a little bit simple. We have chronic hepatitis, we have chronic infection. I'm using a little bit more now of the EASL terminology. I really want to make it clear that the term immune tolerance is out of date. These patients are not immune tolerant. That's been proven by a variety of different viral immunologists. But we can describe inactive disease or inflammatory disease. There's reactivation. There's what's called occult hepatitis B. I just diagnosed somebody with OBI yesterday with some of my colleagues in San Jose Clinic. And of course, you need to be thinking about liver cancer, early detection, risk for liver cancer. There's a number of different interactions that are here. This is one of the most important slides when you're thinking about hepatitis B. This is super important that we be communicating these tests correctly As you know, the CDC has recommended a triple panel testing for all adults in the United States. WHO guidelines will be out in just a few weeks. The WHO guidelines will be announced at APASL Basel in Kyoto next month. And I'm excited to see what they say. I will tell you, during the WHO guideline development, there was a huge discussion about the patient voice. It was in, it was out. I hope the patient voice is back in to the guidelines that WHO is going to discuss. So let's talk here simply. Surface antigen, if positive, equals infection. Our surface antigen test is extremely sensitive and specific. There are settings where you could have a false positive surface antigen test, such as a patient who just received a vaccine for hepatitis B. It was tested a few days later. I've seen 5 cases of that in my clinic in San Diego recently because they're getting the vaccine before they get tested. Really, I think you need to focus on testing, even if it's an hour before the vaccine, but let's do this in the correct sequence. Core antibody equals exposure equals cccDNA. Core antibody false positivity is 1 in 500 people. So if you see core antibody, believe it. Don't go boosting them with vaccine or say it's a false positive. But think about occult hepatitis B. Think about education or testing or assessment for reactivation or reactivation risk. Surface antibody alone with core negative, surface antigen negative equals vaccine-induced immunity. If the core antibody is positive and surface antibody is positive, we use the current term immune control. Hepatitis B in general is incurable, but we're going to get down that pathway of functional cure, complete cure, sterilizing cure in a few moments. There is no healthy carrier of hepatitis B. That's really an oxymoron that was used for decades in the hepatitis B world. Hold on one second. So in a patient who's surface antigen positive, there's a variety of other tests that we do. We're going to assess for hepatitis A immunity, hepatitis C co-infection. In my world, I think every person needs Delta antibody testing. We think there's about 15 million people with Delta today, but less than 5% are diagnosed because we're doing risk-based testing, and risk-based testing has failed. HIV, it's failed. Hepatitis C, it's failed. Hepatitis B, it's failed. As you know, the CDC is recommending triple test for all adults because of the failure of risk-based testing. And Malika Toy's paper with Sam So from the Stanford Liver Center made it very clear it's cost effective to do this triple test from a variety of different perspectives. You're going to assess liver enzymes and liver function. Remember, when you say LFTs, you mean bilirubin, albumin, INR. AST and ALT are liver enzymes. They're not LFTs. I also assess a one-time triple panel for the GALAD score for liver cancer risk. There's also a test from Exact Sciences that's available for liver cancer risk assessment. And very importantly today is NASH assessment. Super important because, of course, you want to treat the fatty liver, but also this markedly amplifies the risk of liver cancer when you have hepatitis B and fatty liver in combination. A number of other staging tools are available. You need to know the stage of liver disease in all your patients. I also look at staging through AST to ALT ratio. You always take a family history for liver cancer and cirrhosis, do a good alcohol history, and if I have any hint of alcohol use, I always do PEth testing in my patients. That's the hemoglobin A1C. There's a variety of other areas that are discussed on this slide. These are the phases that I think that are the best terms from EASL. We have chronic infection, chronic hepatitis, E antigen positive, E antigen negative, chronic infection. And then you have chronic hepatitis, again, E antigen negative. And this is based on looking at DNA levels in ALT. So this is defining the phase of the disease that the patient has. We talked about the stage of disease. But really, we're moving very close globally to treating everybody with hepatitis B. We have the recent Chinese guidelines that have made things quite simple. Let's make this simple in terms of our patient assessment and moving towards elimination. DNA is important because the DNA level relates to liver cancer risk and cirrhosis risk. But these are 2 of 8 different reasons that we're thinking about treating patients. But it is a motivator to get patients on treatment, to have them compliant with treatment. So I think DNA is still a foundational test for assessing your patients. Back to complexity, I'm not going to go into this grid very much, but this has to do with a variety of risk factors, specifically here for liver cirrhosis. Again, it's this complexity that led to our complex guidelines. It's nice to know these numbers, and this came from the REVEAL data that was funded through BMS with a heavy focus on that database from Taiwan. Very, very foundational from about 20 years ago, but this is now just a small piece of the big hepatitis B pie. We don't do biopsies very commonly in our hepatitis B patients since we have such great non-invasive tests, but we still use a simple terminology. But we get to this through imaging and through laboratory testing today, rarely doing a biopsy. And a biopsy would be indicated if you had some type of confusing serology combination of different liver diseases. So biopsy may be useful. And of course, biopsies are useful in terms of drug development. And now we have FNAs that are moving to the forefront also because they're simple and very low risk. So we had a problem. Screening. You had to be able to go through this huge number of risk factors before you decide you were going to do hepatitis B testing. Because of this complexity and how few people were getting tested, we've moved to testing everybody, test all adults. Now, the US had this interesting terminology. They said test everybody up to age 59 and discuss testing with people over 60. The panel that was involved in this testing recommendation and vaccine recommendation said, well, if you have hepatitis B and you're over 60, you're going to die from something else. So why test and treat? Well, I thought that was very, very sort of isolationist because they didn't talk about quality of life, infectivity, treatment as prevention, extrahepatic disease, other types of cancers, stigma that are involved. So let's bring hepatitis B into more of a patient-centric, holistic perspective and not just focus on liver cancer and cirrhosis. So time to test everybody, make it simple, and then walk down this algorithm about vaccination, assessing for other diseases, staging diseases, educating about alcohol avoidance, managing fatty liver disease more aggressively. Let's make things simple. We are not moving towards WHO elimination targets very quickly because of these barriers that we've talked about. You can see the targets on this column, but the being close to this is going to take quite a bit more work. So we also want to have a message about combining hepatitis C and hepatitis B messaging. When the Biden administration and Francis Collins came out with their elimination plan, they were focused just on hepatitis C. We aggressively, through the Hepatitis B Foundation, went in with a hepatitis B message, testing and linkage to care as part of that elimination plan. I'm hoping that will move forward this year. Occult hepatitis B, it's very important to think about this. We talked about the number of people who had hepatitis B globally at 257 million people. And we really can't think about new treatments unless we assess everybody for hepatitis B. We can't think about functional cure unless everybody's been tested and linked to care. Occult hepatitis B is when you have core antibody positivity and are DNA positive, typically DNA positive in blood, but DNA positive in liver, of course, is important. This is again important so we don't waste money on vaccination. It's important because we need to talk about reactivation. I will be sharing a paper on hepatitis B reactivation that's just in the final proof stages. So hopefully within a couple of weeks, if you're on my listserv, you're on my website, we have a beautiful update on reactivation risk. I believe there's over 90 different medications that are related to or place patients at risk for hepatitis B reactivation, mostly because of immune modulation. But of course, we know that treating hepatitis C can reactivate hepatitis B with RDAAs. Now, we have very sensitive assays for surface antigen that go down to 0.05, but now we have super sensitive hepatitis B surface antigen assays that go down to 0.005 or 0.0005 international units. So more sensitive assays is going to find more patients, of course. And our DNA tests are now very sensitive down to quantitatively down to 10 international units per liter. And they can qualitatively get down to about 6 international units per liter. I do have some patients who are quant negative, qual positive, and I typically add a second drug if a single drug's not getting them fully suppressed. Natural history, again, this just goes back to complexity. The reason I'm not going to spend much time on this slide is it's too complicated. And I really think we need to move forward with DNA positive, treat all patients. A little bit more on complexity here, the different guidelines. I've definitely had debates with leaders globally, such as Anna Locke, about this. And she said, well, if you read the fine print, we give the provider a lot of latitude in treating people, but patients don't read the fine print. You see these grids. Primary care providers don't read the fine print. They just see these grids, and insurance companies and governments see these grids. And of course, insurance companies and governments don't have a motive to treat everybody. Unfortunately, they have a motive not to treat people to save money, at least short term. So in 2024, we talked about all these different issues. With stigma, there's discrimination. This is a major issue to people. We'll go globally to a country like the Philippines. Their biggest export is people. Philippine people move around the world in a variety of different service positions. If you have hepatitis B in the Philippines, you are not employable. You're not able to go to different countries and work in different settings. There's a huge issue in China about stigma. It's one of the reasons China has not moved to testing all adults yet. They have a treat everybody, but they don't have a test everybody policy yet. And this has to do with stigma and discrimination. So patient requests, once you educate patients and if patients are requesting treatment, we think that patient voice should be heard. We can't get to a functional cure unless we have everybody tested and assessed. And of course, vaccination, key part of elimination, key part of getting to that cure message. We've gotten rid of the word immune tolerant. That's an out-of-date term, but these individuals with high replication, low activity, low inflammation, definitely have an increased risk of liver cancer and outcomes such as death and transplant. These patients also have all the other factors we've just talked about. So in this series of sevens, these patients, in my opinion, are strong candidates for treatment. I do perform a quantitative surface antigen on all patients. There's a relationship of quantitative surface antigen from this grid and its risk for liver cancer. This is superimposed on the risk for liver cancer with DNA quantification. There's also a infectivity risk. If you have a mother in a low viral replication phase who's pregnant, but high S antigen quantification, there's an increased risk of transmission. There's also related to risk for developing cirrhosis. But let's talk more importantly about whether somebody's clearing surface antigen. That clearance of surface antigen is going to take place naturally in 0.5 to 1% of patients per year. But as we get new treatments, we need to have quant-ass and be able to follow quant-ass. So people responding or not responding to a drug in development or once medications get on the market. So in my opinion, once you have an S antigen that's positive, you need to quantify that and then quantify it once per year. People with hepatitis B or C have the same cancer risk as a person smoking cigarettes. So why not treat everybody? We know treatment decreases the risk of liver cancer by over 70% in patients who are fully suppressed. This is an important message. Let's make it simple. I'm hoping that the new AASLD guidelines that come out will take this approach. We have an action letter coming out from the Hepatitis B Foundation advocating to treat everybody. So let's follow this line. And I really think the Chinese guidelines were very well written, very thoughtful, and have moved to this very, very simple model. Many patients are outside the international treatment criteria, yet they still are at risk or still develop liver cancer. We're missing people. I have spoken with the people at APOSL, and I'm hoping they rewrite their guidelines as well to tighten this up. My advocacy individually and with the Hepatitis B Foundation is to try to harmonize EASL, AASLD, and APOSL guidelines. It's quite confusing. Each guideline has different nuances, different directions, and of course, governments and insurance companies will take the guideline that allows them to pay immediately the least amount of money. Of course, they're not thinking about long-term outcomes typically. So with treatment, we can reduce integration, we can decrease inflammation, and reduce HCC risk. This is a very, very important message. And I really want to get into some details with that with tenofovir in a short time. Suppression is good, but by clearing surface antigen, this is Hong Kong data, you're decreasing the cumulative incidence of liver cancer markedly as you move from that surface antigen positive to surface antigen negative state, provided that they're also DNA negative. So really, our short and intermediate term goals is to get to S antigen clearance. I'll talk a little bit later about some of the new treatments, but the surface antigen clearance naturally or with nukes is at best in the 5 to 10% range over a decade. We're seeing signals with some of the new medications of getting to 10% S loss, S zero clearance rates with treatment as short as 24 weeks. So we are moving towards this functional cure. And when I'm talking to companies and investors about starting or developing or continuing hepatitis B programs, I really think their goal should be a 40% S clearance rate with short-term treatment at a year or less. And this is going to make the complexity of the new treatments, the new complexity. We make treatment assessment or testing assessments simple and treatment assessment simple, then we're going to deal with the complexities of combination therapy that I'll get to a little bit later. And that hopefully will be the last complexity that we deal with. Okay, let's see, get this to go forward. Historical perspective, I started using interferon back in the early 1990s. Lamivudine came out 1998 and 2002. I want to give you a perspective on lamivudine and adefovir for a moment. There's a few provinces in Canada that state that lamivudine or adefovir should be first-line therapy. Totally archaic and, in my sense, malpractice. We had a letter recently from one of the insurance companies in the US that we shared to our Hepatitis B Foundation, where an insurance company in the US recommended adefovir or lamivudine. This just shows you how out of touch they are. I don't think you can even buy adefovir in the United States. I'm not sure where you even buy lamivudine, but this is really terrible. Lamivudine with 50% resistance rates long-term, adefovir with renal and bone and very weak suppression. But today we have entecavir, TDF tenofovir, TAF tenofovir with extremely rare resistance, well described full suppression of HBV DNA, but we're not getting to surface antigen clearance with these medications alone. That's where we're going to get to the next phase. In this indeterminate phase, there's more data on patients with liver cancer risk. There's data that's been published in abstract form from our Korean colleagues describing this peak risk of liver cancer, especially in E-positive patients when the DNA levels 10 to the 6th to 10 to the 7th. In that abstract publication, they talked about very, very high DNA levels having lower risk of liver cancer. But these studies are cross-sectional, so it's very important that hepatitis B is a dynamic stage. Patients move from different phases or stages, and patients need to be reassessed, in my opinion, every 6 months and redetermine about these risks and what phase of disease that they're in. Well, we've achieved a lot already. If you're on treatment, we have mortality reduction, markedly reduced need for liver transplant. Liver cancer risk reduction, we've already talked about. Cirrhosis risk reduction. We can regress fibrosis. That's been shown with tenofovir and entecavir. But surface antigen seroclearance and functional cure, we're not there with our nukes. We're not there with interferon treatment. I haven't talked much about interferon because globally interferon is rarely used. But in China, interferon is still a co-first line therapy. But they've become, I would say, very knowledgeable and very aware that this is related to surface antigen quantification level. So if you pick people with lower surface antigen levels, you're going to have a much higher chance of S clearance with interferon therapy. You have data from the Everest study, including interesting data on combination therapy. But interferon is still listed as first-line therapy, but most providers, due to complexity of interferon, are waiting for the new agents to become available. Histology we've spoken about. E-loss can be up to 50% with nukes. And of course, DNA negativity. 70 to 90% of patients will become DNA negative on a single nuke or monotherapy. Combination therapy, you can get to DNA negativity in 99% of patients. ALT normalization is a problem because people have other reasons for ALT elevation, including alcohol and fatty liver. So this just gives you a little bit of data on S antigen loss with entecavir and TDF. You don't have a lot of data on TAF in terms of S antigen loss, but even as potent as TAF is, and it's my favorite nuke, S loss rates are quite low. So we really need to be making a major next step with our therapies. And fortunately, pharma investors, patients, investigators are investing in these new treatments we'll talk about. So long-term treatment, but one thing we don't use is lifelong or indefinite. We give our patients hopes. With 30 new medications, more than 10, actually I counted recently 16 different antiviral or immune targets that we are really have great hope for the future. This is just issues briefly looking at entecavir versus TDF versus TAF. What's the risk for renal disease or the presence of renal disease or bone disease? Fortunately, entecavir has no renal or bone issues, but there is a slightly higher risk of resistance with entecavir. And if patients aren't fully suppressed on entecavir, you can switch them to a tenofovir compound and capture another group of patients to get DNA negative with monotherapy. We have made things simple. This is on the University of Washington website. A group of us, including primary care, hepatology, infectious disease, came together and created a 5-page guideline, still too complex in my opinion. If you look at our recent publications on 5-line guideline, so those 5 lines is really all you need to know about hepatitis B from a simple perspective. Then you can go into the layers of complexity once you've assessed those 5 components. You do still measure E antigen in all of our patients at baseline, and of course we want to see E antigen loss. But as you can see, treating indefinitely until S loss is really the terms that we use. But I really want to move to treat until we have new therapies, or S loss is my terminology with my patients. So let's get back to these cure messages that Sanjaya was talking about. We have what we call a functional cure, which is S loss and DNA negativity. That's what we're focusing on, although the partial cure column on the right side was discussed in the last AASLD EASL workshop that was published. It took a year to get it published this last year because the meeting was 2 years ago, which is where you have a reset on your DNA level to a low DNA quantification, but you remain S antigen positive. You do like to get to the point of complete or sterilizing cure on the far left side, which is in that setting of removing all of the integrants and removing cccDNA. We do have some new technology modifying the epigenetic structure of hepatitis B, modifying the cccDNA and clearing cccDNA with CRISPR-like technology or ARCUS-like technology. So there's some very exciting companies that are now gone public with their technology that may actually get us to a complete or sterilizing cure in some patients. Very excited, but of course, I'm always an optimist. This is another slide that talks about these different types of cures, what's going on with the patient serologically or from a molecular perspective. And this slide deck, of course, it will be shared out through Sanjaya and your website. And I hope this is being recorded. I didn't see the recording button, but this is really gets into some more details. It's quite helpful. So a little bit more here, making this grid simple, and it is the functional cure where we are going next. Retract B, this is an algorithm based on S antigen loss and quantification. A little bit complicated here, but this is something that happens. We think from the Hepatitis B Foundation, up to 40% of patients stop nukes on their own. And of course, there is a risk of flares and death, but these are really anecdotes that happen, but they're real. If you're a patient, you flare, you need a transplant, you develop liver failure. But we think in a subset of patients with low S antigen levels, we can withdraw a nuke therapy and get to S clearance in up to 15% of patients. This is much more common in adult-acquired hepatitis B, Caucasians specifically. That's why there's Caucasians and Asians on here. If you're Asian, you're thinking about withdrawing or stopping nuke therapy. The S antigen level really needs to be less than 100, but that happens, you can get to that 100 level. You can have a high rate of S antigen loss, and this has to do with immune reactivation and then viral clearance. Now we're going to switch back to what these medications, this is specifically TDF, does to reduce the number of transcriptionally active viral integrants in hepatitis B. So this is interesting that our nukes are changing what's happening with the viral integration and what protein they're making, which is about 95% S antigen, 5% X antigen coming off integrants. Integrants never make a full-length virus, but they're making S antigen. And if they're making S antigen, you're thinking you haven't had functional cure in your patients, even though you may have cleared all the replicative intermediates. But this viral integration message is important in terms of liver cancer risk. I don't know exactly why that went forward, but anyway, you've got my message. So our on-treatment goals now, of course, are DNA negativity. Long-term treatment is S antigen loss with finite treatment. From a patient perspective, patients really want a year of treatment or less, especially if they're going to be on a complex regimen with different types of injections, including monoclonal antibodies or antisense oligonucleotides. So less than a year, preferably 24 weeks, would be great. And we want to get to S loss rates that are in excess of 40%. A little bit more on stopping nukes. I'll let you read all these details later. The reason I'm bringing this stopping nukes up again is the whole issue about this risk of reactivation and close monitoring of patients. And this reactivation risk is why you will tell patients to stay on therapy. And if they're going to stop therapy, they need to be monitored. I do want to go back to a foundational discussion about hepatitis B vaccination and the fact that we have two great vaccines that are, I think, an advance over the Merck and GSK vaccines. One is Hepatitis B, that's made by Dynavax in Emeryville, just a few miles from where I'm sitting right now in San Francisco. And we have the VBI 3-dose vaccine, which is a triple antigen vaccine. This VBI vaccine has been in development for over 20 years. Our colleagues in Israel really helped, and Danny Shuval really helped bring this forward. And a modified VBI vaccine is now being used by Bree Pharmaceuticals in terms of hepatitis B functional cure. So we have a lot going on in the vaccine world, but the most important thing is getting vaccine to our patients. 2-dose vaccines has a higher compliance rate than 3-dose. These new vaccines have very, very high surface antibody titers. But the message I want to have here is that we don't test after vaccine. We don't boost after vaccine. We have data out 35 years in Africa and Alaska showing that once you've had this vaccine, thanks to memory cells, you don't need to be boosting patients just to get a cosmetic surface antibody. Okay, let's see if I get this to go. This is just a little bit more data on where some of our successes are and where some of our failures are. China's done a fantastic job in terms of coverage of timely birth dose. I do want to mention here about timely birth dose. If you look at the paper from Thailand, where they didn't use HBIG or couldn't use HBIG in their patients, the birth dose within 2 hours of birth reduced the risk of transmission almost to 0%. So if we can get vaccine to the baby within 2 hours of birth, we probably don't need HBIG, and we might not even need tenofovir in our patients by that super early dosing. Vaccine is making a difference globally where this has been instituted. You can see, again, we're just talking about China as an example because it has the largest number of hepatitis B patients in the world, has moved their dial from a hepatitis B surface antigen prevalence far over 8% down, moving quickly to the 4, 3, and 2% range, depending on which age group you look at. One more comment I mentioned earlier about correlated antigen. This is a slide I borrowed from MFU and from the Hepatitis B Forum presentation at the AASLD this last year. That this correlated antigen is a test that you can get through Fuji Rebio. I could also order it in the United States through Mayo Clinic. It does allow you to fine-tune your assessment of patients and their different phases of chronic liver disease. The detectability or sensitivity is being improved. There's a second-generation correlated antigen assay that comes out. This is being looked at as a easy, simple blood test to talk about what's happening with hepatitis B replication, more importantly, what's happening with cccDNA. So correlated antigen, you're going to be seeing published extensively in manuscripts and oral presentations on new drug development, but you can think about using this potentially in your clinical practice. The data is emerging. The Abbott new core antigen assay is probably better, but we're waiting for more data to fully embrace this. So back to treating everybody. Everything in yellow here has to do why you should treat everybody who's DNA positive. If you're in a resource-limited country where DNA testing is $100 and tenofovir is $50, there are models such as what Homi Razavi has put forward that states that you should treat everybody who's surface antigen positive because it's cheaper to treat than to test HPV DNA. So very, very important issues here. One more thing I want to bring up is fatty liver, that at least a quarter of hepatitis B patients have fatty liver, and that obviously markedly increases the risk for liver cancer development. So we've talked extensively about the 5-line guideline. In my opinion, this slide summarizes the most important facts you need to assess or communicate to your patients and your colleagues. Test all adults with the triple panel. Vaccinate all adults who are triple panel negative. If patients are surface antigen positive, link them to quantitative DNA and Delta antibody testing. good news in the US, LabCorp has Delta antibody testing, and within 90 days, they'll have Delta RNA quantification. So all the 4 major labs in the US will have easy access to Delta testing. I think this should be done globally, and these tests should be available throughout the world. Rapid or point of care testing is also being developed for Delta antibody testing specifically. Treatment. This is a new news. Treat all individuals who are DNA positive and treat until S loss plus 12 months for consolidation. Stage all of your patients so you can decide then on surveillance techniques for liver cancer early detection. This makes it simple. I think the 5-line guideline could really move the dial towards elimination. And of course, we find patients as we come up with new therapies for functional cure, we can get those patients moved into treatment. What are barriers to functional cure? Well, we have a very complex viral host immunity interaction. There is later phases where these patients have what's termed immune exhaustion or clonal deletion. And it could be that a patient who's 60 with hepatitis B may not respond to some of these newer therapies, whereas somebody 20 years of age with a completely different immune profile may respond to 2 therapies. So we may end up having to personalize treatment for our hepatitis B patients in the future by having immune profiling. And I think we're getting close to this. Adam Gehring in Toronto is one of my gurus in this space. He says we're not quite there yet, but I think within 2 to 3 years, we'll be able to immune profile our patients to further determine what phase they're in and what's the best new treatment for those individuals. So we have many new therapies. As I mentioned, there's 30 drugs, 16 targets in the hepatitis B world. We are getting signals from GSK with their BEPI studies, Vir using iRNA and monoclonal antibodies, the BRE data that came out with interferon and therapeutic vaccine, where we're getting over 10% S loss. This is really exciting with therapies between 24 and 48 weeks. Let's go quickly through this cycle. We have entry inhibitors. Bulevirtide is one of the examples, but that's involved with Delta. It does not have much effect on hepatitis B in terms of replication, even though it's blocking entry. But there are other medications that may enter this space, including our monoclonal antibodies may serve indirectly as entry inhibitors. We have a number of different tools from a molecular perspective with RNA interference. With iRNA, there's at least 4 different iRNA drugs that are moving into the clinic or in the clinic today. GSK recently acquired the Arrowhead iRNA from Janssen and also acquired their CPAM that was in development. Nukes, these are polymerase inhibitors, quite simple, and that's why they're not changing S antigen levels, but they're potent suppressors of viral replication. I think the CAMs, the CPAMs, capsid inhibitors are a foundation of new treatment. And then, of course, you can block release through what are called NAPs or stops. The Alagos data, though, showed that this type of technology did not work. Replicor is still doing research with their NAPs. There's not a clear pathway for Replicor to get to approval. On the right side, we're talking about a variety of different immune modulators with anti-PD-1 or PD-L1. There's a T-cell engineering studies that have come out of Singapore. Vaccine therapies, there's at least 7 different types of therapeutic vaccines that are in development right now. And this can modify B-cell and T-cell antigen-presenting cell activity, de-repression of dysfunctional T-cell responses. Interferon is really has many effects, and different types of publications have shown up to 30 or 40 different types of immune modulations with interferon. But it's a little bit like throwing spaghetti at the wall and see what sticks. Interferon is a crude method, and we're fine-tuning that. We have toll-like receptor agonists, which unfortunately to date haven't shown a major level of activity, but there are still some that are in development. The RIG-I compound is not in development further. We are modifying interferon-stimulated genes with some of our different technologies. So take a look at this combo therapy. We inhibit replication. We talked about some of the different tools we have here in the blue box. Antigen reduction. There's a drug from Enyo in France that's an FXR agonist that modifies hepatitis B replication, but it's faded just because it wasn't potent enough. There is an RNA destabilizer that's been looked at on and off, including by Arbutus. And of course, immune stimulation is highlighted on the right side. I've mentioned these different classes of drugs that are here. I think it's going to take a 3 or 4 drug combination to get to this 40% functional cure. But patients are willing to undertake this level of complexity if they have that high level of coming off therapy and having sustained suppression. Let's talk for a moment about the VIR study. This looks like it's just building on its own. This is called the MARCH study. A lot of data here, but sorry, there's something like it just wants to do things on its own. Let's see if I can go back. You can look on the right side in the gray box where they had S loss rates at 15% with this combination therapy. Complex slide, you can take a look at this later, but I'm showing you this to say we are getting signals. There's a little bit more on this VIR data. It talks about the patients, what their clinical and virologic and immune profiles are. And this is still using pegylated interferon therapy as part of combination. I mentioned Brie with our therapeutic vaccines using pegylated interferon. So peg interferon is still part of our armamentarium, but needs to be looked at, in my opinion, in combination. siRNAs, this is Arbutus on the left with S antigen reduction, and on the right, the J&J data. So this thing likes just to go ahead on its own. But there's something interesting about the iRNAs where you're getting this only 2 to 3 log reduction. You can't get more. There's a whole discussion about the iRNA and saturating the RISC complex, the turnover of the RISC complex, the turnover of the iRNA. But it's very interesting with the GSK program by buying and bringing in an iRNA and combining that with their BEPI ASO. If you lower that S antigen by 2 to 3 logs, suddenly your other therapies become much more attractive. You're bringing those patients into that favorable range of less than 3,000, less than 1,000, less than 100, and then you're going to have a much higher probability of getting to that S loss rate that we've described. Let's see if I can get this. This is Aligos, and let's see if hopefully that will stop. Still just likes to go forward. All right, this is Aligos, came out now with their first data with their CPAMs, looking at surface antigen change by multiple logs with their 300 milligram dosing, plus or minus entecavir. So we are getting signals now that the second and third generation CPAMs are lowering S antigen and taking us closer to that functional cure. This is looking at nivolumab and a therapeutic vaccine study. Of course, this seems like it just wants to go forward on its own. I'm going to go back. Must be something turned on these slides that I can't detect. So vaccine plus a checkpoint inhibitor really modified CD8 responses. And this type of data with PD-1 and PD-L1 modification has led to companies like Gilead bringing forward an oral checkpoint inhibitor. We're trying to get away from injection therapies as much as possible. Delivering those checkpoint inhibitors to the liver also, I think, would make a big difference. So there are signals out there that this can be part of our future armamentarium. This is data back on BEPI. Let's see if this is going to be going forward or not. Hopefully it's stable. And this is a 9% of patients with 24 weeks of therapy achieved S antigen and DNA loss that was maintained for 24 weeks after end of treatment. So this is very important to say short-term treatment, 24 weeks. We've moved S loss rates now to the best we've ever seen with nuke therapy at 5 years or 5 years plus stopping nukes. And this is telling us that we are moving in the direction of a better functional cure. Let's see if I can get this to go forward now without. So I think we're close to the top of the hour, Sanjaya. Oh, it's exactly 60 minutes. That's amazing. Thanks for having me. Hopefully this is giving you a great world into hepatitis B. I talked about Delta very briefly, but I really want Delta to be on everybody's radar. And I think I'll go just stop sharing here and turn it back over to you, Sanjaya. Thanks everybody for being part of this today, and I look forward to more interactions.